This is Lab Medicine Rounds, a curated podcast for physicians, laboratory professionals, and students. I'm your host, Justin Kreuter, the Bowtie Bandit of Blood, a transfusion medicine pathologist at Mayo Clinic. And today, we're rounding with Dr. Jeff Meeusen, an assistant professor of laboratory medicine and pathology and a clinical chemist in the division of clinical core laboratory services for the Department of Laboratory Medicine and Pathology at Mayo Clinic. Thanks for joining us today, Dr. Meeusen.
Hey, thanks for having me. I'm really glad to be here with the Bowtie Bandit.
That's right. So one of the things in that introduction, which is totally on point and appropriate with where you're working, for some of our listeners that may not have a good sense on what that means and what you do and how you participate. So could you give us a little bit of that lay of the land and kind of explain for our listeners, how does the cardiovascular laboratory provide patient care?
So as you said, I'm a clinical chemist, which is atypical in the medical field, or at least less common. So my training is in chemistry, and then I do an extra certification in all the medicinal parts of that are necessary. So not a traditional physician, but rather a Ph.D. path. And CV lab medicine, or cardiovascular lab medicine, is more of a program at Mayo Clinic. We do focus on diagnostic lipids and lipoprotein testing that is for patient care. But it was actually started by Dr. Alan Jaffe, who is a practicing cardiologist at Mayo. And his vision was always more than just a four-walled place where we do CV lab medicine. He wanted it to be a place that we bring in specialists, medical lab scientists that have deep expertise in their technical operation of their methods, but also in cardiovascular, or at least an interest in cardiovascular sciences. And it's a place for chemists like myself. We even have alternative lab medicine professionals that focus on point of care testing or stat testing, out in the ER, in the hospital, genetics experts and pathologists. And it's a place where we all routinely interact. We have a regular meeting system or schedules, and we can all talk about what's working, what's not, and what's the coming down the pipeline, so to speak, in cardiovascular lab medicine.
That's really interesting. I'm glad you're highlighting the fact that, you're coming from this position of being a clinical chemist, because, this whole idea of, bridging the laboratory medicine and the clinical practice to help people understand that we have a lot of different professionals coming from different backgrounds that are participating in patient care. And so right there, as you were saying it, you corrected me that it's really a program that you guys have set up rather than a laboratory per se. And I was wondering if you could kind of maybe elaborate for us, what does that look like? Maybe a specific example of what does that look like when you've got clinical chemists, cardiologists, other professionals in the laboratory. That might be an interesting concept for all of our listeners to kind of understand.
Yeah, absolutely. One of the first ones comes to mind is precision medicine and genetics. So as I said, I'm a chemist. I'm not an expert in genetics, but in the last few years, there's been this rise of at-home genetic testing and even an increase in clinical scale full genome sequencing. And so there increasingly has become patients that have already been exposed or already have results in hand when they come to their doctor and say, look, this says I might have a risk for a heart attack down the road, or it says my risk is in such a percent category, high, medium, low. And we were not necessarily focusing on that in my cardiovascular lab, but in the CV program, we had genetics experts like Linnea Baldwin here at Mayo that were already thinking about these things and were well aware of what the appropriate genetic tests would be that have clinical, strong clinical data to support them, as opposed to those that really are more just for the at-home testing kind of education market. And so that was, I think, one of the first examples I could think of a really good use of this ability to interact between a genetics expert and the cardiovascular lab program.
Let me kind of ask you and kind of dig into that example a little bit that you talked about. One of the challenges that sometimes comes up with these groups of people from diverse areas is I think the goal is fair to say that the goal isn't to have different layers, right? You're not trying to make a sandwich and like you got your genetics in there, you got your clinical chemistry expert, but to really blend something together with everybody's components. I think I previously used the example of a smoothie sort of output. I was kind of curious, can you talk a little bit about how bringing these people into the laboratory and developing a test that, as you're describing, provides a lot of value to patients? How is that blended and really that's the output?
So again, it comes back to, I think it was an intentional design by Dr. Jaffe that while we did have this lab and that would be focused, we would make sure that we had regular meetings that brought all these experts into the room and gave them a chance to interact. We had one just this morning where they can say what's going on and give their input and feedback. And beyond just the genetics and the pathologists and the lab medicine expertise, we actually have practicing cardiologists as part of our group as well. So Dr. Jaffe himself is an interventional cardiologist. And we just recently brought on Dr. Vlad Vasile, who is a practicing cardiologist here at Mayo, and he's in preventive medicine. So he keeps track of more, what are the biomarkers we should be looking at people who are at risk, et cetera. So I think it's just having that regular meetings and keeping people involved, even at an operational level, that's really led to some success in us being able to keep at the cutting edge of cardiovascular lab medicine.
Okay, let me hit pause here, Jeff. So
Yeah.
you're talking about meetings that you guys do. I think all of the listeners, we know meetings, and there's a certain connotation that comes out of this. That's and so maybe if I could push back or ask you, how is this meeting not just some hierarchy of people that come together and who we all know who the top rooster is or whatever, like how do these meetings actually work as this sort of interprofessional, really utopia is what it sounds like?
And maybe I've given the wrong impression by focusing down on a meeting. Really, it started out as co-directorships. There is no director specifically. So from the very beginning, we had, even though the primary appointment might be in genetics or cardiology, they are part of the operational working group. When we are signing out cases of lipoprotein metabolism, they are on the rotation. So that's why they're actually there in the lab, on their day, and they're aware of all the ins and outs of what we're doing operationally. And so therefore, they're also giving input routinely and regularly as where we ought to be going as a group.
That's brilliant. Yeah, Jeff. And I'm glad we kind of highlighted that. So for the listeners, right? I mean, to have meetings with a bunch of people in the room is nothing new. Yes, there's nice things about that, but as you really focus on, it sort of sounds like the secret sauce is that structurally it's been organized so that there isn't a hierarchy. You mentioned that you've got co-directors, and so people are on equal footing that are coming from very different backgrounds, so that it really kind of forces collaboration to happen. Is really what I'm hearing. Did I hear that right?
That's exactly how it's been built. Yes, with that intent.
Yeah, and then the other aspect that I heard you say that just to highlight is the fact that it sounds like this is regularly occurring, on a pretty much nearly a daily basis. these sorts of interactions. So it isn't like a, monthly, we're having an organizational meeting. That's not the secret sauce. It sounds what you're describing is it's a regular, ongoing, equal footing relationship. And then that has organically evolved over time.
That's absolutely correct. Down to the point where now there's doctors that maybe used to be part of our sign out rotation, and now they're back to more of a full-time appointment in the clinic seeing patients, and they're emailing us and paging us about patients throughout their day regularly to really improve that interaction between the clinic and the lab and the service we can provide to the patients.
Jeff, you're making my heart go pitter patter now. This is the tagline of this podcast is bridging that gap between laboratory medicine and the clinical practice. And you just describing there is these clinicians that have participated in the lab, that have been phased into more of a clinical practice heavy outside the lab job. They're continuing to actually talk to you on a frequent basis. That brings up a question that I have. So you've got people that are sort of, I don't know if the right word's anointed, that understand, right, that are on the clinical side. How does that work for maybe those that are not, that don't have that experience? How do you keep the other cardiologists or other clinical colleagues aware of what's happening in the lab and updates for what can impact their practice?
Yeah, and so it's back to, as you say, it's not necessarily a structured meeting, but it's being in the room. It's being together on the floor. And so because we have a couple of cardiologists that are on the floor here with us in the laboratory every week, they're also on the floor over in the clinic every week. And so I'd say they're our primary source of driving those interactions. They're able to know what's happened in the lab, and then they bring us over to the clinic when we need to interact with back to, there's an operational focused initiative happening, and they say, you know what, we need to have the lab aware of this. We need to have them involved. For instance, the practice and the labs were both aware of troponin upgrade coming down the pike. So troponin is the test we use to identify a person that shows up in the emergency department with chest pain. We want to know, is this person having a heart attack? And troponin's become the gold standard. All the vendors were about to switch. So lab medicine was already aware that there was going to be a new kind of troponin test. And because we had this interface, and we were able to make sure that the practice was aware that this is coming, and it's going to change how you see the numbers and what you're able to do, because the new troponins that all the vendors were going to switch to, we didn't necessarily have a choice, was going to be so much more sensitive. So we were worried. We wanted to make sure that the docs were understanding what the new values would mean and treating their patients appropriately. And because we had this interface of clinicians and lab, we were able to not only have a system built in place and ready to go, we were probably one of the first institutions to adopt and start running with high sensitive troponin when it became available. And this was just a couple of years ago. So this interface and constant interaction between the clinicians and the laboratory is really setting us up for success in a lot of ways.
Wow, I love that example. And it really kind of shows then what this investment in this kind of a leadership structure, and then I think clinical practice structure can mean. It sounds like it's really given you people that are advocates in the clinical practice that have either been a part of the laboratory or have come to, from their colleagues, learned the value of it. So you're upfront being participants in change that's happening. Jeff, is this something that is are other laboratories kind of adopting this model that you're aware of, or is this something where this great experiment in the cardiovascular laboratory here at Mayo has been rather unique?
So the bit of the sea change recently in that we're now not a four-walled entity. We've actually divided simply into core chemistry and special chemistry. And to that end, we've had to build up more programs. So cardiovascular lab medicine program already existed. Now there's a pediatric lab medicine program that is able to bring in pediatricians within their subspecialties and the experts in the various lab medicine subspecialties to really try and drill down and focus on that. There's a kidney disease lab medicine program that was also born out of this, that has been trying to, again, have this interface of clinicians that are closely working in the lab, like Dr. John Liskey and Tim Larson, who are both practicing nephrologists right here at Mayo, that are also actively involved in the lab medicine community so that they're able to bridge these conversations and interactions.
One more follow-up question on that. I'm curious because as you're describing that, right? You're in a laboratory that has some history doing this. And as you say, more recently, we've been expanding and there's been some new groups and new people pulled in. So I imagine that's both from both sides, new laboratory medicine people that are now in this new kind of co-director structure. And then also there are clinicians, like you mentioned, pediatricians that are now in this structure. I'm curious, what are your thoughts around what have you learned about kind of, establishing that culture or getting them to understand what the plan is?
It's about finding the right people. And once you put out there this concept, the people that are interested tend to find you. So Dr. David Sass is a nephrologist, pediatrician nephrologist that ended up finding the renal laboratory group and has become more and more involved and just being part of the operation again. So he, sitting in and having an assigned rotational duty to be, part of the lab, then gives them the connections and the interactions so they can start leading projects that say, really what we need to do for the sake of pediatric patients is this type of testing or reporting it in this context. And that's really made, I think, a lot of impact within chemistry as a group and within, the clinic for patient care as a whole.
As you're saying that, I had this image. I've recently watched that movie Miracle about the hockey team from back in the early 80s. And I'm reminded of one of the quotes from that movie was that the coach, he wasn't looking for the best players, he was looking for the right players.
Yeah.
And that kind of flashed up as you were saying, like, you put out the call in a certain way and it sort of attracts a certain kind of individual. And it's that's what it sort of sounds like, is it's really important who is coming to the table.
Absolutely.
I want to close with kind of thinking then about our medical laboratory scientists, and hopefully there are some people that are going to college and thinking about a major and stuff, and always like to encourage medical laboratory scientists, and of course I always try to recruit them to transfusion medicine. But I'm curious, what's your pitch, Dr. to get them to go over to clinical chemistry?
Clinical chemistry is the place to build your career if you're interested in variety. So we have all the fun toys, all the variety and the full spectrum of things you want to do. We've got high throughput machines where you're feeding it 1,000 samples an hour and keeping up with all the workflows that entails. We have some workstations, and this is all happening right now in our chemistry lab. We call it alchemy, because you're literally mixing A and B and watching for a color change, and you want to see what's happening there. We've got mass spectrometry, where you're distinguishing between different molecules based on their molecular weight. We've got electrophoresis, where you're separating out macromolecules and picking the band that has the analyte of interest. We got nuclear magnetic resonance spectroscopy, where you're able to look at 500 things at once by their proton spin. So if you're interested and having a variety of opportunities and technologies to learn from, chemistry is the place for you.
Man, with a pitch like that, I understand why sometimes not everybody goes into transfusion medicine. And also with a pitch like that, I think hopefully for our listeners too, I mean, the breadth of what Dr. Meeusen was just describing there, it showcases just the breadth and also hopefully the depth of background and expertise that clinical chemists like Dr. Meeusen brings to a laboratory and then ultimately translates into value for patient care.
Yeah.
So thank you so much for joining us, Dr. Meeusen.
I really had a good time. Thanks for inviting me.
So we've been rounding with Dr. Meeusen, and thank you for joining us today. We invite you to share your thoughts and suggestions via email. Please direct any suggestions to mcleducation@mayo.edu and reference this podcast. If you've enjoyed Lab Medicine Rounds podcast, please subscribe. Until our next rounds together, we encourage you to continue to connect laboratory medicine and the clinical practice through insightful conversations.